All right, so today I'll be talking about our project, building a provincial intake assessment to strengthen equitable access to cancer care in Alberta. So this is our new fancy Cancer Care Alberta background here. So just a bit of information about Alberta. So we currently have two tertiary cancer center sites within Calgary and within Edmonton. So you can see in the yellow and in the pink there. And we have four regional sites. So our tertiary sites are our main centers that treat all of the different tumor types, whereas our regional sites, smaller communities within the province, but still take new referrals in and see the big four, I call them breast, lung, GI, and GU. And then we have 11 community cancer sites. So those sites primarily treat with chemotherapy, usually in suites, but they don't intake new referrals. So most referrals will go to our tertiary sites, and then if people are in a rural area, they may be referred into a regional site. And we're located down in Calgary in the yellow there. All right, so background. So the start of our project, which everyone would have maybe heard of initially when Claire and April had presented, but this started back in 2023. There was an evaluation of the navigation and referral practices that took place, and it was identified that there were barriers that people were facing when accessing cancer care. And there was a need that was highlighted that we needed to help increase access for people earlier in their cancer journey. It was also found that 25% of newly diagnosed individuals needed support and they couldn't access them at that time. We also know that as symptom complexity increases by stage, meaning that if someone's referred in with a higher stage cancer, we know that they often have higher needs as well. And in the current state, we had no consistent way of actually identifying who those people were and who needed extra support at that time. Also recognizing we have this period of time between when someone's referred into the cancer center to when they actually have their first consultation. We kind of call it this in-between period where people are left kind of not really knowing what's going on. So we thought, how can we access those people in that period of time to help provide more support for them? So our project overview, we do have an equity focus with this referral intake that we've created, and it was meant to help support these newly diagnosed people. We also worked at kind of establishing pathways to connect people with resources within cancer care as well as resources within their community. So we developed this standard intake assessment. We're a little interchangeable with what we call it, assessment, referral questions, referral intake. Essentially, it's a set of questions that are asked to a patient to help understand who they are as a person. And these questions will go along with that new referral intake process. So when someone's actually being triaged into cancer care. And as we spoke about, we are endorsed through executive leadership. So there's been good support from our operational leaders about having this project get going. So some of the key concepts in development, we really wanted to focus kind of on this equity focus. So reducing inequalities, increasing access, and looking at what those barriers to care are for people. Because if we can, help provide a bit more support for people in that in-between period, maybe they don't miss their first appointment. Maybe they're able to get access, they don't have a car or they have someone they're caring for at home and they can't make that first consult. Understanding who the person is, because realizing, being diagnosed with cancer might not be like the main thing that that person is trying to manage within their life. So just a understanding of kind of how we started to design the intake assessment. So before I joined the team, Claire and April did a lot of engagement with internal partners, patient and family advisors, and then also a lot of our community partners as well, and worked with them to kind of understand what their goals, what feedback they could provide to what would be helpful knowledge to know and include within our intake questions or assessment. There was also a literature review done of tools that are currently used. So, although cancer care is not using any, there's like the Spark tool, which is used by some community groups just to understand barriers to care. So, looking at those different tools and how we could incorporate those into ours. We didn't want to use, take the Spark tool and be like, okay, we're going to use this tool specifically, realizing that, cancer care is very different. And um, when we planned to put this in was really early in someone's cancer journey. So we wanted it to be, sensitive to the patient, that we're not asking questions that could be, would break that relationship with or kind of harm that relationship with the healthcare system. So we wanted the questions to be really open and just understanding and helping us to understand who you were as an individual, where some of these tools got into really specific details on the person. After there was a draft created, so when I joined the team, that there'd been a couple drafts that had gone through already, and we went back to some of our partners to then review the draft and take a look at the intake questions, and we requested feedback from them and incorporated that into further drafts. It was many, many different drafts and redrafts of what it was going to look like. And then the final step that we kind of did in the design phase was that we reviewed and tested with our patient and family advisors. So I actually met with some of our patient and family advisors and asked them the questions and had them reflect back on their experience to how they would have felt if they heard the question themselves. Did the question sound like, would it have been helpful for them at that time? Were there questions that they didn't really understand? So it helped us to just use it in more of a real capacity. Also, my colleagues can jump in at any time if I'm missing anything too. So the engagement. So this is kind of the piece. This has happened, before, also during, and we've also been connecting back with these groups as well. So we've had a lot of engagement with site managers throughout the province, ensuring that they're aware of what we're doing. We've presented at some of the navigation forums. So we spoke to uh, the actual nurse navigators to see if this would be helpful for their work, to understand some of these different barriers that patients may be facing before they even call them. Social work has been heavily involved, helping us to get an understanding of how to ask some of the financial questions, or even understanding maybe some like red flags to this person needs a referral to social work. Like this is someone that can be referred to social work if they answer questions, about maybe housing, or they're really struggling financially. Can we get them linked with social work earlier? We have our Integrated Cancer Diagnosis Committee, which they're working on developing processes for earlier kind of, um, I guess, diagnosis of patients. So while they work on that pathway, we're hoping that we can kind of integrate our work into that as well. Patient and family advisors we talked about. Um, it was reviewed with an equity advisor to read through. Community health clinics. So there's two that we've been working with quite closely, Radius and Alex in Edmonton and Calgary. And those community health clinics often are kind of a link to patients that maybe are unhoused or don't have a lot of trust within the healthcare system, but have built a relationship with this community health clinic. So working really closely with them, so we can almost have bi-directional pathways with them if they have someone that may need the support of the cancer system, or the cancer system needs the support of the community health clinic, going back and forth. We've met with Queering Cancer. Wellspring has been a big piece. Wellspring, a community support for patients within the community that can help with peer support, programs for patients, and how can we get people linked up with that earlier in their journey. And then different Indigenous groups within the province, Métis Nation of Alberta, an example of one of the groups that we've engaged with and received feedback from. So just an idea of like where we're trying to put this in. So when a new referral comes into CCA in this little purple box here, maybe triaged by, a clerk might be looking at it, a nurse might be looking at it. And then within that time of it being triage, that second step, or within kind of that same step too, is that intake assessment might take place. So along with triage, building that understanding of who the patient is and what supports they need at that time. And then our final pathway here is just kind of looking at how then can we link those people with the resources that they need. And in the white boxes here, just some examples of resources people might need to be linked with. Cancer Care Alberta resources, maybe specialty navigation. We've got um, adult and young, well, adolescent and young adult nurse navigation, Indigenous navigation, as well as metastatic advanced cancer navigation, and then also community resources. Realizing that maybe not everyone needs this really specialty navigation or a referral into a community resource that is helping support someone with housing, but maybe they just need peer support or maybe they can self-navigate. We recognize not everyone's going to need a high level, back on that first slide, we talked about 25%. So not everyone will need the support, but how can we still link people with community resources that they might need to reach out to? So the topics of the intake assessment. So um, a lot of feedback received on these. These are what a lot of the questions are about, but I'll kind of go through and I'll talk about what some of the questions are. I'm not specifically going to bring up the questions today because we are still trying to, I guess, finalize what those questions are going to look like, but I can definitely talk more about what they look like based on each of these domains, I like to call them. So demographic confirmation, of course, we would confirm who the person is. Ideally, like, is that we want this to be like a phone call to the patient so that they have that kind of connection with the cancer system rather than it just being maybe a form. But there's lots of opportunity, in the future too. Like eventually, maybe this might be a flow sheet or a form, but to start, we're looking at doing this in a phone call. So demographic confirmation, who's the person, communication, this might include if somebody needs translation, can translation get set up before the patient actually comes into clinic? Daily life, this one focuses a lot more around kind of those social supports. Could be transportation. How is the person getting to and from their appointments? This also is housing as well. Where is the person currently living? And do you have any concerns with where you're living? So this one would help us to open the conversation about, if somebody doesn't have a home, can we get them set up with community supports or earlier with social work so they can start looking at options for this person? Daily life also includes things like mobility, understanding how a person ambulates. Financial, this one, we wanted to talk a little bit about insurance too. So understanding what a person's financial situation is. Do they have any concerns with um, just making kind of like, we actually went back, like, this was an interesting one because we kind of talked a lot about, like, do we say, do you have a hard time making ends meet by the end of the month? And we had a lot of different variations of that question. And interesting enough, we kind of came back in the end to it being a question like, do you have financial concerns? Because we need to realize that this might be someone where this conversation could be translated. So having these interesting ways to word it or things that we would like as a primarily English speaking person, be able to say making ends meet, that might not make sense to someone who is new to the country or has to have it translated. So it's interesting. We've had a lot of talk about this, about how you make this inclusive for everyone to understand. Virtual care with this one, we included a piece about hearing and vision because we recognize that hearing and vision can have a lot to do with someone not being able to have a virtual care visit. So we've put that into this section, but then also have included, people might not have access to a phone or might not have access to the internet. So indicating this to the healthcare team that this person doesn't have access to a place they can take a phone call is important for somebody's care because just from my own personal experience, you've called someone before and You can hear that they're trying to care for their children in the background, or they've got a bunch of family members in the background, or maybe they don't want to share something on the phone because they're sitting in the living room with their daughter and their mother. So understanding a person's situation with that. Self-rated health, we went through and we had a couple questions about physical and emotional health and just giving kind of a broad rating on it. So looking at, how are you feeling today? What is your physical rating today from one being the worst to five being the best? And just to help getting an understanding of who or where that person feels they themselves are rating their physical or mental health. May also help us to make referrals to certain things too. Maybe they do need to speak to a nurse because they're in a lot of pain, or maybe they are really struggling mentally and they could benefit from a referral to psychosocial earlier. Oncofertility is one that we added a little bit later into the intake assessment. But this one has been quite positive with people that we've tested with. We really wanted to just talk to people about, again, we've gone through very different variations of how this question is worded, but um, asking people if they're interested in speaking to somebody about their fertility. And in this case, they can be referred to a fertility clinic that might need to talk to them before they start their treatment. Yeah, we keep kind of going back and forth too about when's the best time to ask this person this question. And all the patients we've spoken to as well all recognize earlier is better. Um, so just opening this conversation, maybe the person hasn't thought about this or this is the first time they're hearing about it. It at least it opens the conversation and it lets people start think about, what are my thoughts on that? And then resources I just have at the end here, our opportunity to kind of set people up with some of those community resources that might be available. So testing within Alberta. So far, this is kind of what we've done in terms of testing. Like I mentioned, we met with the patient and family advisors and I went through the questions. We then did some specific testing with some clinicians in practice. So we had a nurse practitioner and a registered nurse at Arthur Child ask the questions. They worked with a very specific population. They worked with advanced disease GI patients. And so we got some interesting data back from them about how patients responded, and we were able to see the symptom burden that these patients that had more advanced disease, or the fact that they needed more referrals. So it was very interesting getting some of that testing data back. And then the second group that we tested with was within Grand Prairie, and we did testing and evaluation, and we actually had clerks ask the question. So it was interesting to get a bit of uh, a different, a different healthcare provider ask the questions because of the differences in their scope of practice, where we would see the nurse practitioner and registered nurse get very detailed in their conversation about certain topics. The clerical staff were fantastic in being able to ask the questions and record the answers and then pass on that information to the nurse navigators. So it was neat to see how the two kind of groups interacted, and I've got a bit more information on that as well. And you can see I actually stole these slides from Ashley. So thanks, Ashley, for these amazing slides. She brought together some of our evaluation data about some of the testing that we've done already. So the two sites I mentioned, Grand Prairie and Arthur Child. I will mention that the clerks that helped us in Grand Prairie were very high functioning clerks, very fantastic. Like they could really dive into the questions with patients and felt very comfortable. Kind of, if something came up, they could kind of direct the conversation with the patient and knew how to like de-escalate things if, say, someone got upset by a question, which thankfully nobody did. Patients were really very grateful for being asked these questions. So in total, we had 23 patients responding. It actually ended up being a bit more than that because the clerks liked using it, so they kept using it a bit more. But the information we looked at was 18 from the clerks and then 15 by the RN and NP. In general, it took the clerks 8 to 10 minutes to ask the questions, and the nurse NP about 2 minutes more than that because they tended to get a little bit more detailed in some of the responses. Not not too surprising, but the biggest concerns, of course, were financial for people. And there were 8 referrals from those 23 patients. 7 of them were social work being the most common and related to the finance piece. And we did find that, of course, within that advanced disease group, the GI pilot, they did have more referrals. So those people, had a few more barriers that they were dealing with. Some of the real-time support that was provided by our um, that the staff were able to provide to the patients is it was interesting. It kind of brought up other things that maybe we didn't include, but it allowed the patient to kind of be open in talking to the healthcare provider about ways they needed support. Like the one patient didn't have a computer, so that was good information for us to learn, but couldn't print things out. One patient needed to be helped with the online platform, so we were able to sign someone up, and they helped their daughter get set up as a proxy. And the MP helped to sign someone up for additional drug coverage that they knew they were going to need. So again, another benefit that was something that happened sooner than if they had to wait several weeks to get in to see oncologist. So in this group, we had looked at both groups together, but 35% required additional support, which is higher than the 25%. But again, this was a more complex group that we were with the GI pilot. Higher needs is what we kind of took from that. And then it also really brought out for us what some of the team-based nursing, or sorry, not nursing, but team-based approach that we saw between the clerks and the nurses. So the clerks, they were already, like a lot of them were already talking to the patient and, working with them, but they felt like it gave them this sense of like they were there to help the patient a bit more, and they felt like they were more valuable team members as well, being able to collect this information. And it also helped us to make more real-time referrals to the nurse for psychosocial or social work. So when they asked the questions, they were able to make those referrals in time rather than in that waiting period where the person's sitting at home waiting to find something out. Initial identification of needs enable our nurses and physicians to dig deeper. So this was important because we found that the clerks would identify someone maybe would need social work support. And then when the nurse navigator would give them a call, they were really able to dig into that specific question rather than, going through their regular list of questions they would ask. This actually helped them to they realized there was an issue there, it helped them to dig into that. Um, we also think it'd be a helpful way to help triage as well, based on maybe someone doesn't need a call. They're self-navigating okay with stuff on the internet. They don't need a nurse to call them to then give them further navigation support. And also documentation. So this piece is important that these questions were getting asked up front before they had their consultation. Um, we need to make sure that we have a way to document within the chart so that the healthcare team can see that information, and it's not this duplication process where one team member is asking, then the next team member is asking, then they're asked again 10 different times within 2 weeks. So what's a way that we can have good communication between what's asked within this intake assessment to when the patient is seen in clinic? So where do we go from here? So that initial testing took place. We've looked at that data, and then we actually are going to do some pilot testing as well. So looking at hopefully we can capture all patients that we see. So Grand Prairie very kindly has offered to be our pilot site. So we're going to be working with them and Grand Prairie is up in northern Alberta. It's one of the regional sites, so not a tertiary site, but a regional site. So they take new referrals in, but smaller volumes than we would see through Calgary and Edmonton. But our goal is that we're actually hopefully going to capture all new patients, and then we can really look at the data that comes in. They see sometimes up to, I think they were telling us like 25 a week. So we're hoping that we can get a lot of data that we can look at and build off of that. So we're also going to look at how many referrals are made based off of that. Wellspring is actually new to Grand Prairie, so we've been working to strengthen that connection with them so that we can refer patients based on this intake assessment to their programs. We've updated our patient and family partners, so we met with them recently to just go through what our next steps are, similar conversation to what we're having today. And so they're aware of their contributions to the intake questions and, some of the feedback that we've gotten back from some of the testing. And then we also are going to be working to make sure that we provide good education to the team up in Grand Prairie because it's important that um, we know what we're collecting and everyone's able to provide the right referrals and maybe they need training in maybe de-escalating a conversation. So how can we help support them to make sure that this pilot runs smoothly? And then so for considerations for the future, so uh, we want to try to, of course, our initially wanted this to be role in the time that I've been in this role, but um, there's been so many different changes and things that we've learned, um, especially differences between the different sites that we've noticed that, just rolling this out provincially, we're really going to have to understand how it works on a site first before we move there. So we want to align with provincial workflows um, and priorities, but it's important that we really understand how this tool works and clarify how it works with different healthcare professionals. Clarify the healthcare professional role. We're even thinking, maybe this tool might be used by different professionals. It could be a clerk at one site. It could be a nurse navigator at another, just based off what we're kind of starting to understand about different workflows at different cancer centers. Operational implementation, we want to ensure that there's like consistent, clear documentation within the electronic medical system. So we're working at building that so that people will use it, we can pull data from it, that type of thing. Education for patient intake, we talked about how we want to provide support to these different sites. Are there other pilot opportunities? We are going to probably need to test this in a tertiary site as well to understand how it works with a much higher volume of patients where maybe not every patient can get called, unlike Grand Prairie, where they currently do call every patient. And then this phased provincial rollout, which big dreams here, but it's, what's that going to look like when we roll it out throughout the province? So my last slide here, sorry, I realize I've talked for a long time here, but just some of the key messages that I kind of like to think about when, what was the purpose of this, approach for us is that we want to identify barriers to access and care for patients and ensure that we're continuing to have this person-centered approach to cancer care. Um, recognizing that equity is kind of the focus of what this tool is. But we're also trying to target these different things like this waiting period between diagnosis and first consult, engaging people with their community partners and healthcare workers within the build, and then taking all of that, developing this standardized tool that we want to use that helps create more equity and um, addresses those barriers to care for people. And that's it.
Thank you so much, Erin. That was fantastic to see the evolution of kind of where things were at a year ago and then where you're at now. Um, I have so many questions.
Great.
This is interesting too because we are doing something similar here, but we haven't quite started yet. And so I think a lot of the things that you talked about are questions that I have about how this project is going to unfold. Um, I'm sure there are maybe other people with questions, although I recognize that most of the people here today have a lot of knowledge of your presentation. So maybe I will start, and I'm wondering if a question for any of you that have been involved in the project. Have there been conversations about the potential increased strain on resources if you're starting to suddenly identify like these needs have existed, but we have not been asking the questions. So, for example, finances, housing, and now suddenly there's this influx of referrals to social work, and like how to manage that increased demand. It's just something I can see coming up in our project, and I'm not sure how we are going to manage it.
Mhm. Yeah, I think we've spoken a lot with social work about this, and we've wanted to almost like work with them to identify like what red flags would be. So it's not that every single person that has financial, yeah, I'm struggling financially. Well, I'm struggling financially too. Like we're all kind of, struggling, but also recognizing that there are other resources out there, like maybe this person can be referred to Wellspring to take the financial matters course, or maybe this person can be mailed a brochure or a pamphlet that talks about how to manage finances.
Mm.
Um, but not just like us sending everything over there. We've also had that a bit with Wellspring as well. Like, we're like, oh, this is great. We're gonna just click refer, and every single person who says yes is gonna go over there. But yeah, that would have a definite impact on their resources. So trying to identify, and we have worked with them, and it's part of when we ask the questions, we're also trying to have some like um what's the right word for it? But like if the patient says yes, there's like going to
That
be
was my
other
next
things
question.
to kind of,
Yeah, is there sort of like an algorithmic
yes,
flow to it? So if this, then this, or but if they answer this, then maybe this is the like obviously there's some clinical reasoning and
yeah,
assessment involved, but you can't for most providers, I would think they can't know everything that exists out there and
for
kind of
sure.
how to address it. That's a big challenge.
Yeah, and it's also we're thinking too, like we're also not going to be able to know every single resource that's available within the province either. Like
Yeah.
something that's available up in northern Alberta is not going to be available in Calgary. So relying on the staff within those individual sites too to know what the resources are available to them. Yeah, that's been important too.
And so is there conversation, and I acknowledge your hand, Ashley, and so I'll stop talking momentarily. Is there conversation about tailoring the assessment tool to context? So, maybe Northern Alberta, the questions are the same, but the algorithm like maybe is a little bit different because the resources are different? Or
Yeah,
is that
like
an eventual down the road?
I think like we don't want to get too much in the weeds with that, or
Okay.
else we're going to be at every single site, but like trying to figure out what, they need to have on their algorithm, but
Mhm.
recognizing that that information already exists. Like a lot of this work is already being done by the navigators when they call the patient and they set them up. This is just more of a like a way that we are kind of standardizing it across the province and ensuring that um, all the questions are being asked the patients that need to, because a lot of them, like a lot of our nurse navigators have giant binders filled with all the resources that they already refer someone to that
Right.
I would have absolutely no idea what those resources are. So, um, yeah,
Great.
it's just like the project's kind of just like gotten, as we found out more, it just feels like it keeps getting bigger and bigger a little bit. But
Mhm. Yeah.
yeah, Ashley, do you want to go ahead if you have more to that?
I was just gonna say that I think one piece of information that we learned in the pilot was that with one of the groups that we piloted with is that asking the questions in a more direct way enabled them to tailor their referral a little bit better. So for example, like, hearing not just that it's like a social work, but it's like this specific issue could lead to the person being able to self-navigate with resources. So we like that could lead to like a um, information like, a referral or like information about Wellspring or whatever, like Erin said. But then also like if it is a social work referral, it's like more specific. So just like helping to kind of like so that when, the person that follows up on the other end, whether that be like the physician or whoever, the nurse, the next person to see them is like, okay, so you said something about this. Can we talk about this? So there's already been that a little bit of an introduction of what the need is. So like maybe time saving down the road. And then I guess like big picture is kind of that like thinking about all the people that, miss appointments and things like that because they didn't have transportation or they didn't have anyone to help them out, or they get to their appointment and they don't have Blue Cross and so they can't get on their treatments. And so I think that the idea is to like, is there some things that we can do in that waiting period that might save time later for the clinician. So I think those are like philosophically the arguments that we kind of also need to be making. It might not, we don't have evidence of that yet, but I think yeah, I think it's something to pay attention to going forward in these projects for sure.
It's a really great point, and it's interesting. We're doing some data collection right now for a different study on lung cancer and access to care. And actually, someone raised that exact point is that in some circumstances, people are waiting a while before they get that first oncology consultation. And while we may be not able to administer treatment during that period, we could be doing things if we knew about these needs, like, there was a kind of a interesting example given around they need to have filed their taxes in order to be eligible for this particular benefit. And if no one knows that up until the first consultation, well, now we've just delayed it another however long. And so, yeah, it was really interesting. I hadn't really considered that before, that there are things that we can do in the waiting period that actually facilitate that access down the road. But we can't do anything if we don't know about those issues. Yeah. I don't want to dominate the conversation. Does anyone else have any questions?
You should just use this opportunity to
I'm
ask
going to.
your
I have
questions
more.
because this is the team. They're all
I
here.
was gonna
Yeah.
say, fire away, Tara.
Okay, great. I'm wondering like what you have planned or either upcoming or have already done around training the people that will be asking the questions.
Yeah, so I think part of it, like our first step is that I am going to go up there. Like I want to go into Grand Prairie to actually be present to help kind of understand what their current processes are.
Mhm.
But we've been looking at some of the things April and I have kind of thrown around have been like doing like presentations where we maybe go through the questions with them and practice asking them, especially if a lot of nurses, like we have found that they've asked these questions before, they might have the experience with it, but we've found working with the clerical staff. Right now, we're working with really high functioning ones who we haven't had to provide a lot of education to. They know how to ask these questions. They know how to, bring it up to the next level if there's something that they're struggling with. But we might potentially have to have other clerks that were trained to do it. So we want to make sure that we have really great like scripting for them as well. So scripting is important that they know what to say. So I think a lot of it's just going to be kind of engagement with them, understanding what resources they currently have and what are things that they can also refer to, such as Wellspring or things like that. We were thinking of getting Wellspring to actually come present to them to let them know what resources are available within their area. Um, what else am I missing, April?
I can't think of anything off the top of my
Yeah.
head.
I think it's just trying to like engage with them in person as much as we can to like understand where they need support.
And
In
was there like, have you talked about the benefit of um, providing some foundational knowledge around like why are we asking these questions and like why do these things, how do they impact people down the road if we don't address them? Like, I'm
You
just
mean
wondering
for
how
staff?
deep we go.
Yeah, for staff, like
Yeah,
education.
yeah.
Yeah, yeah, that's actually a really good point. I
Think
don't know
I
if
don't
we've
think
done a lot with the staff for that.
we haven't, but I actually think one of the micro learning modules that Krista Marson will be sharing is really focused on that. So Krista Marson's modules, they're all through the Walking Together Indigenous work. So they do have an Indigenous focus, but the one that she mentioned that we've collaborated on, it really is a situation that isn't specific to Indigenous patients. It's like somebody's late for their appointment. What are some assumptions you might make? And then we actually look back and it's this and this and this and all these different factors and facilitators and barriers. So I think that something like that will work really nicely with that exact piece.
Hmm.
I'm just thinking, yeah, for my own clinical background, sometimes there may be a temptation amongst staff to skip questions or
Mm,
maybe word them in a different way if you don't really know why you're asking what you're
Yeah,
asking. And
totally.
so it was something that's been in the back of my head for my own project is how much are we going to dive into the why that we're doing this? And wondered if you considered that.
I
Mhm.
think it's You bring up a good point because I don't know if we've like explicitly considered it with staff, but I think in all of the engagement, we've been including that type of messaging. Like every time we're talking with the frontline team, when we first introduced the testing opportunities, at like even as we talk about the pilot with Grand Prairie staff, it
Mhm.
is we try I think we've just always really tried to remain focused on like this is why we're doing this because we see this like we have this very clear gap in how patients get support and knowing that we have long wait times there's this opportunity to take advantage of like how can we put supports in place ahead of that consult, what does that mean kind of going down the road. So I think we've sort of like I guess kind of from a change management lens, we've always incorporated that type of
Right.
messaging in all of our presentations, but I don't know that we've like formalized it as part of like, hey, we're going to do this pilot. Here's your 1 hour training session. Step one, we want to make sure you understand the importance of this. And
Mhm.
I think part of what we're seeing too is because we have this provincial electronic health record, we may skip questions, but it may be because we can see the information already. So some pieces, like we're kind of talking about how there needs to be like a chart review process so that you kind of go through, look for certain information on the patient. And so the question may be less about like asking you if you have hearing and vision changes, but more about saying, I see this information documented. I want to make sure that it's correct. Or do you have anything that you'd want to add to that or something like that? So I think that's it's helpful for us. So thanks for pointing that out because we can make sure we integrate it in our training.
Well, and I
I
think
just think about
the
it. Oh,
other thing,
sorry.
sorry, Tara, to interrupt you. The other thing is I think what I've seen you just because I've been also watching their process too. Like I'm like researching the team too, so it's like I'm always just watching them, like a creep. But it's like also that like I think you guys have been really good at acknowledging the work that's already happening, and I think that the clerks are already like setting up appointments, like fielding a lot of these questions around like transportation issues. Oh, do you have someone to help you? Oh, like, and it's just not necessarily been like documented or like communicated. And particularly in like the rural remote areas, it's like they're using like relationships to like facilitate these things. So it's like almost like and I find like with our one like kind of test site, it is really about learning their practice and learning what they're already doing and then how we kind of like tailor this equity intake assessment into the work they're already doing. So we're really trying to avoid kind of this like here this is a whole new brand new thing and more like you are like there's a lot of the aspects of this work that you will be really familiar with, and so that's really been interesting feedback because they're like we often feel like we're the frontline people when people come in and we know a lot about patients but we're not necessarily part of that care because we're admin right or whatever that is, right? And but it's like it just speaks to how the need for that kind of interdisciplinary uh work together to really like to build on the strengths of everyone that's like on the team too, right? There's a lot of knowledge that exists in the people that work behind the desk too, right?
Absolutely. And I think to your point, well, a few people have made a point around documentation. It doesn't always make it into the chart, and if it does, it's maybe not done so in a place where it's going to get looked at again,
Yeah.
or there isn't an intentional process to actually go and look for the
Yeah.
information. And so then you're in the scenario where it gets asked over and over and over, and people may
Yeah.
start to feel stigmatized or just
Yeah,
annoyed that you've
exactly.
asked me
And
the
that's
same
such a huge part of
question.
equity. And April's been so good because every time, we come up with these ideas, April goes, okay, let's figure out how to get this into the system, right? And it's like that work that's really the theoretical and the conceptual work and everything around the equity questions and stuff. But then also it means nothing if you also don't have somebody who's working like on that documentation, that movement in the system, which has been really cool to for me to witness anyways, as
Yeah.
being an outsider in all this.
Oh, I feel so
Yeah.
special. I will say one thing that we've really noticed with like just from other experience and like our work with patient reported outcomes and stuff, there has been a lot of talk about like our workflows in the new electronic health record and how I think the approach that is typically taken is like, here's the functionality, figure it out, figure out how it works for you, kind of thing. And I think what we're really hoping to do is flip that a little bit with this in terms of like, how do we make the system work for us? Because we also know that how these questions get asked, if we're going to like scale and spread across the province, may look really different. It may be different roles. It may be clerks in Grand Prairie. It may be nurses in Arthur Child. It may be very different. And so part of the challenge will be figuring out something that's can be consistently used across all of those roles, but still, and then always like captured in like a meaningful, visible way. That's probably going to be the hardest part.
Well, I feel like I'm going to be knocking on your door again because that has already been identified as a potential
Mm.
challenge in our project, although we were really starting quite small, and the scale and spread is years and years down the road. But thinking about some of those considerations from the beginning rather than creating this thing that we then have to
Yeah.
completely change and revamp if it's going to be scaled and spread elsewhere. Maybe I'll end. This is probably not a short question to end on, but if you could summarize in like 1 minute or less, what has been the most challenging part of the project so far, if you could pick one aspect.
Oh my God, I have that right off the bat. I think for us, it's our bigger context. It's the wider changes that have been happening in our health system that have trickled down to completely grind us to a halt in
Mm.
many different ways. And I think like there's that, all of these big changes happening. And as you can imagine, we don't love the ideology behind some of these changes.
I can't
Um,
imagine.
Especially given that we currently are now looking at like a full-on privatization onslaught, et cetera. So it makes it pretty tricky. But I think the other piece that has, I don't even think I realized this until maybe even the last month, but having sat in the space of this project since we kind of initially started to a degree, and how even just within cancer care, the like our provincial kind of pieces of work around referral intake and referral triage. Like we did that evaluation forever ago on our cancer patient navigators, like the navigation program, sorry, and referral triage intake. And that really highlighted the gaps. Like that's where we really saw a lot of the gaps. But that also was taken organizationally, and now there's provincial teams working on how do we standardize referral intake, how do we make consistent guidelines so that regardless of where a referral flows into the system, everyone's doing kind of the same thing at the same time. And so I think that context just within the organization has been sort of slow to get to a point. The work is now starting to get moving, but we're also recognizing like that's probably our best way to sustain this is
Mm.
actually integrating these questions, this approach in that work. And that's, I think it's a bit of a hurdle because it's currently in a space of a project management team that is very much like, here's my lane and I'm staying in my lane and I have my objectives and my deliverables. And then we come in and we're like, oh, wait a minute. Like, we really think we need to like insert this here. And they're like, no, no, no. That's like something totally separate because they're seeing us as in a very specific lane and a separate stream. So I feel like that's going to be a little bit of, I don't know, that's where Linda comes in moving forward and helps
Yeah.
kind of just advocate for that more integrated approach. And they're trying, like, we definitely can see that integration maybe a bit better, but yeah, I would say that's one of the big things. I don't know, Claire or Erin, what would you add to that?
Yeah, I was going to say in the restructuring, cancer care has felt less impacted than pretty much any other health department. So I think we have been fortunate in that way. But I would agree that just the differences between every single site. When we wrote this grant years ago, very optimistic and oh, we'll just implement provincially, right? And that's just not realistic. But I think that it also gives a really good opportunity to tailor, for example, the education materials. Like Erin said, we have these really high functioning clerks in Grand Prairie. We may not have them everywhere, but that gives the opportunity to really tailor the training package. Or, the patient population does differ between sites as well. So like tailoring that. So I don't know. I'm a optimist. I'm trying to spin it as like it's a good thing because we can be more tailored in our approach, but it is a challenge.
Sure.
Mhm.
Erin, is there any last words you want to share with us?
No, just that I would agree with those two. I think like I'm excited for the pilot. I think it's going to give us a lot of information. So I really like looking at the data from things. It helps. I feel like it just helps to really bring things together. And like April said with that group, I'm hopeful that, we'll get this data and be able to share some really strong evidence on why this work is important with that group. And yeah, it'll hopefully build our case on why we need to be integrated into that referral process.
Wonderful. Well, thank you very much, Erin, for leading the conversation and for the others that have jumped in and shared your experience. This is really important work. It's really exciting work, and I'm looking forward to sort of observing how things go and comparing notes with you over the next few years. So thanks very much. Appreciate your time. We're going to end for today and hope to see everyone back in February.